Well, let me welcome you all to the 5th annual Aero Lecture. This has been a fantastic series that we've had for the last 5 years to honor one of Columbia's most distinguished graduates, Ken Arrow. One of the reasons that we were enthusiastic about having the lecture series is that we thought at the time that we would have one lecture every year sort of featuring what happened to a contribution that he had made 30, 40, 50, or 20 years ago. And it covers such a span of topics. The first one was on following up on his paper on learning by doing. The second one was following up on his paper on his book on social choice and individual values. The third was on financial markets. The fourth was on work on global warming. And this is the fifth, which picks up on basic work that Ken did in 1963, where he developed concepts of moral hazard in the context of health insurance. And he solved the problem then, but unfortunately, the country didn't fully take on board the analysis, and here we are many years later still talking about health insurance. So we thought we were really pleased that Amy Finkelstein was willing to give this talk because it is a topic that is of enormous current interest. A topic in which there's actually been a lot of good economic research, and hopefully we'll be able in this talk to bring together some of these policy issues with the basic economic research. Amy Finkelstein is professor of economics at MIT, co-director of the public economics program at the National Bureau of Economic Research, and co-editor of the Journal of Public Economics, journal which I helped found many years ago. She researches in public finance and health economics, primarily focusing on market failures and government intervention in insurance markets and the impact of public policy on the healthcare sector. So after Amy's presentation, we're going to have three discussants talk about her work, and I guess I'll wait and introduce them until after Amy's talk.
Well, thanks, Joe, for having me. It's a great honor to deliver the 5th annual Arrow Lecture. When I was first asked to give this lecture in honor of Ken Arrow and on the topic of the economics of healthcare, I thought that this would be very simple. As you all know, and as Joe just alluded to, Ken wrote a seminal 1963 paper entitled Uncertainty and the Welfare Economics of Medical Care. So my plan was to talk about how this paper has shaped and influenced the subsequent field of health economics, a field which, by the way, didn't exist when he wrote the paper. And it's really striking to reread the paper because you quickly realize that virtually everything that has happened in health economics in the last half-century can trace its origins back to that paper. But that's also when I realized that I had a real problem, because I only had 50 minutes to talk about the wide-ranging impact of the paper, and even I can't talk quite that fast. So I've come up with a two-pronged solution. Next year, for the first time, we're offering a semester-long graduate health economics course at MIT. And we can organize that course entirely around the paper. As an aside, I should say, in light of the recent Supreme Court discussions, there has been some debate among our faculty as to whether our new graduate health economics course should be mandatory. You can imagine where my colleague and discussant, John Gruber, comes down on that issue. And he may have more to say about that later. But what I'm going to do for today is to focus on just one aspect of Arrow's original paper, and it's one that relates to a topic I've been doing some research on for the past several years, and that's the economics of moral hazard. People have hands up, they can't hear. Is this better? Yes. Okay, I'll try and talk louder. Maybe someone can mic me. Okay, just to begin by trying to put today's topic in perspective, I wanted to remind you about essentially the two central facts of the US healthcare system. The first is the lack of health insurance by approximately 46 million people. So about 15% of the population currently doesn't have insurance. The other is that healthcare spending is a large and growing share of our economy. So in 1960, only 5% of GDP, 5% of the economy was spent on healthcare. Today, that's 17%. And that has real implications for the public sector. Spending on healthcare is currently 20% of the federal budget, and it also is a substantial share of state budgets. And so from a budgetary perspective, this is just a graph from some projections the Congressional Budget Office did a few years ago showing federal spending, so this is leaving out state spending, as a share of the economy, as a share of GDP. And at the time they did it, federal spending was about 20% of GDP. As you can see, it's forecasted to grow much greater to over 35% of GDP, and essentially all of that growth is coming from public health insurance, from Medicare and Medicaid. So at least from the expenditure side, the budget problem, such as it is clearly heavily influenced by spending on health care. So not surprisingly, the recent healthcare reform, the Affordable Care Act of 2010, tried to address both these issues. It focused on trying to cover the uninsured and to rein in the growth of healthcare spending. But there's a fundamental tension in these goals in that by itself, accomplishing the first goal exacerbates the second problem, right? But by itself, if you do nothing else, insuring the uninsured is likely to increase healthcare spending. And why is that? That has to do with the moral hazard effects of health insurance, which is the subject of what I want to talk about today. As far as I know, Ken can correct me in his remarks, the first academic reference to moral hazard in health insurance, not insurance in general, but health insurance in particular, was in his 1963 article, and he defined it as the idea that medical insurance will increase the demand for medical care. And in that article, at the end of the introduction, he lays down a gauntlet for subsequent researchers. He says, and I really like this quotation, the discussion is not designed to be definitive, but provocative. I wish I could get away with that with my referees today. In particular, I've been chary about drawing policy inferences. To a considerable extent, they depend on future research for which the present paper is intended to provide a framework. And indeed, it did so. And so what I wanted to talk about today is how have we risen to this challenge that he laid down in this article now almost 50 years ago. And I really wanted to talk about two questions. One is just an existence question. Is the idea of moral hazard, which is an interesting theory, is it empirically relevant? Is the demand for medical care really price sensitive? And the second, which is sort of rising to the challenge he poses, is to translate this idea into its policy implications, and in particular to get a sense of how alternative health insurance policies or contracts are likely to affect both the level and the growth of healthcare spending. So I wanted to start just by some definitions. So what do we mean when we say moral hazard in health insurance? As I said, Arrow defined it as medical insurance increasing the demand for medical care. Now, why would that happen? There's sort of two ideas out there in the literature. The first, which is due to Ehrlich and Becker, has come to be known as what's called ex-ante moral hazard. This is the idea that if I have health insurance that's going to pay my medical bills if I get sick, I have less of an incentive to invest in maintaining my health, because if I get sick, the financial consequences of that are now going to be borne by somewhere else, and therefore I'm going to eat, drink, and be merry, right? Or smoke more, drink more, exercise less, etc. The second idea, which was formalized by Mark Pauly in a 1968 article, is what's come to be known as ex-post moral hazard. So that says, conditional on my health, so forget about this idea that health insurance may affect my investments in my health, let's just take my health as given, I'm going to choose to consume more medical care for a given amount of health because the price of that medical care is lower. That's the whole point of insurance. If I go to the doctor, I'm not paying out of pocket for all of that or perhaps any of that. So it's basically about a demand curve and the price sensitivity of demand for medical care. And for the most part, and for most of what I'm going to talk about, the literature has tended to adopt the second definition. Moral hazard in health insurance has come to mean price sensitivity of demand for medical care rather than an impact of health insurance on investment in one's health. I'm going to talk a little bit about some empirical evidence that's sort of consistent with this notion that there doesn't appear to be a huge health investment response to health insurance. And I think it's kind of intuitive once you think about it, because even the best health insurance that covers all of your medical expenditures is only insuring that, your medical expenditures. It's not insuring your health. So when you're deciding whether or not to smoke, even if when you get cancer, when you have health insurance, all your chemotherapy will be paid for, you haven't insured against getting cancer. And so that may be why we don't see as much of a behavioral response in investing in your health. So focusing now, and this I'll do for the remainder of the lecture, on this second idea, this price sensitivity of demand, I'm going to start with what is ultimately just an empirical question. We can argue about it, and I'll describe some arguments that have been made, but ultimately it's a question for the data of whether medical care is sensitive to price. Now, this certainly seems like a natural property of any demand curve. I know we don't like to make analogies these days between broccoli and health, but it is true that the demand for broccoli slopes downward. If you lower the price, people buy more of it. You might think that was true of basically any good. There is an alternative view out there, however, that medical care is not determined by price, it's determined by needs. And one summary of this, of what I'll call the rhetorical case against the notion of moral hazard in health insurance, was put forward in a relatively recent New Yorker article by Malcolm Gladwell. This is from 2005, in the article, so you can guess what the gist of his article is going to be or his argument is going to be by the title, is called The Moral Hazard Myth. And a quote from this article is, he says, "The moral hazard argument makes sense only if we consume healthcare in the same way that we consume other consumer goods. And to economists like John Nyman, this assumption is plainly absurd. We go to the doctor grudgingly only because we're sick." And then he quotes Uwe Reinhardt as saying, "Moral hazard is overblown. You always hear that the demand for healthcare is unlimited. That is just not true. Do people really like to go to the doctor? Do they check into the hospital instead of playing golf?" Right? And in fact, Malcolm Gladwell in this article goes on to make the argument that the myth of moral hazard is a vast right-wing conspiracy. It's been propagated by the right as a way of preventing universal health care in America by arguing fallaciously that it'll increase health care spending. So that's the rhetorical case. What exactly is the evidence? As I said, ultimately it's an empirical question of whether when you give people health insurance, they'll consume more medical care and thus increase health care spending. And empirically it's somewhat challenging to get at this. You don't want to just compare people with and without insurance and look at whether people with insurance spend more than people without insurance, because people with insurance are different than those without insurance. They have different income, different employment status, different health, and these in ways that are likely correlated with the demand for healthcare. As we know from Joe Stiglitz's work, we think people who are in worse health are going to be more likely to purchase health insurance, right? And in fact, if you just do these crosstabs in the data, you'll quickly discover what looks like moral hazard. People with health insurance spend more on healthcare than people without it, and you'll quickly discover that it looks like health insurance kills people, because people with health insurance have higher mortality than people without health insurance. I mean, those are the tabs that I've done, and so that might give you some pause on just making these types of observational comparisons. So, the ideal solution here to test this null hypothesis that Malcolm Gladwell and others have put forward, that there's no moral hazard or no price sensitivity of the demand for medical care, would be a randomized controlled trial in which you randomly assign different insurance across individuals, right? And then you see, so you don't have the selection problem. I didn't choose the insurance because I was sicker. I was randomly assigned it. And this allows you to actually infer what the effect is of giving insurance to one group and not another. Remarkably, there have been 2 randomized controlled trials in the United States on health insurance. You can think that that's remarkable either because it's such an important topic, how could there only have been 2 randomized control trials, or it's such an expensive thing to study, because to actually do one of these experiments, you need to go well, in some cases you have to actually pay for the health insurance, and at a minimum you have to go survey them and collect information on them. If you want to know what happened to their health, you have to go do physical exams. So you can view the glass as either half empty or half full, that there have been 2 of these. One which John Gruber and I have been involved in, that I'll talk about in a moment, was from a Medicaid lottery in Oregon in 2008, and it's ongoing. And the other is the Rand Health Insurance experiment going back to the 1970s. So let me just describe the experiment, and then you can judge the evidence for yourself. So Medicaid, which is public health insurance for the indigent, in Oregon, they have an expansion program to cover people who are financially but not categorically eligible for Medicaid. So essentially, these are low-income people. They're below 100% of the federal poverty line. This is really poor. This is less than $10,000 for a single person in annual income. they're uninsured, but they're able-bodied, so they're not getting on Medicaid because they're on welfare or they're disabled. They're not otherwise eligible for Medicaid. Oregon had money to cover some of the low-income uninsured adults in this group, but not all of those that are eligible. So they thought about how best to do this. They decided it was not fair to award their limited slots. They had about money to cover 10,000 people on a first-come, first-served basis, because that would privilege people who were better connected. Federal law actually prohibits you from awarding Medicaid on the basis of health status. So they decided the only fair and equitable thing to do was to run a lottery. So they ran a big public relations campaign. They asked interested individuals to sign up. About 90,000 low-income adults signed up, and they randomly drew about 30,000 names to be eligible to apply for Medicaid. We have results now from the first year of this experiment, and more is ongoing. But just to give you a sense, this is just one of many pieces of data. This is looking at the probability of hospital admission over about a 16-month period after the lottery. The dark blue shows you the probability of hospital admission for the controls, those who didn't win the lottery. We're not technically allowed to call them losers, but you can think of them in that sense. And they have about a 7% admission rate over a 16-month period. And the light blue shows the implied increase in the probability of going to the hospital for the treatment group, the people who were won insurance. And you can see that it's about 2 percentage points or 30% higher. And then, so that's sort of, that's empirical evidence from a randomized controlled trial that is belying this notion that demand for medical care is not price sensitive. No one wants to go to the hospital, so they're not going to do it even if it's less expensive. What's interesting, if you look at the other two bars, we broke up hospital admissions into those that come through the emergency department and those that don't. And perhaps not surprisingly, what you see is that almost all of the increase in hospital admissions is admissions coming not through the emergency department. These are presumably ones that are less serious or less time sensitive, and therefore perhaps not surprisingly more price sensitive. So it's a fairly intuitive result. There's a whole bunch of other evidence we have from just this first year. In the interest of time, I'm not going to show you a lot more pictures, but just to summarize it, we see increases not only in hospital admissions, as I just showed you, but also in the taking of prescription drugs, in going to the doctor, et cetera. And if you figure out the cost of all of these things, we basically estimate that having Medicaid for this population is increasing annual spending by about 25%. So people on Medicaid, when they're randomly assigned it, are spending 25% more, which is about $750 a year for this population than those who aren't on Medicaid. So I think this is fairly compelling and definitive evidence rejecting the null of no spending effect of health insurance or of no moral hazard. And as an aside, we don't find, at least in this first year, although things could change in later years, any evidence of this notion I talked about earlier of ex-ante moral hazard, that now that I have health insurance, I don't have to take as good care of myself. So for example, we don't find any change in smoking behavior. Now this may be because this theoretical possibility that when I have health insurance, I'm less concerned about my health isn't actually operative, or it might be operative and counterbalanced by the fact that people with health insurance go to the doctor more and the doctor is urging you not to smoke. So that's something that remains to be sorted out, but it's consistent with sort of the intuition that there's not much of this ex-ante effect. I want to also briefly mention the other health insurance experiment. This is the famous Rand health insurance experiment from the 1970s. And here they randomly assigned about 6,000 individuals to plans with different levels of consumer cost sharing. So unlike in the Oregon experiment, when you're comparing the random assignment of public health insurance to having no insurance, here, well, these are all private health insurance, and everyone in the experiment is getting insurance. They're just differing in how comprehensive the health insurance is. This was led by Joe Newhouse, actually one of our collaborators on the Oregon experiment, and it's summarized very nicely in his 1993 book. Just to give you a sense of what they did, so they randomly assigned different types of plans. The most comprehensive coverage was called the free care plan. There was zero cost sharing, so zero that the consumer had to pay out of pocket. And then there were a bunch of plans where the consumer had to pay something out of pocket, depending on what you were assigned. Maybe you had to pay 25% of your costs out of pocket, 50%, 95%. One thing I want to note, and I'll come back to this in a little while, is that all of the plans had low out-of-pocket maximums or stop losses, so that even if you had to pay 95% out of pocket, you had to pay that only up to some maximum amount, which was about $1,000 in 1970 dollars, after which you then had insurance cover everything. So that even the people in the least generous plan still had catastrophic coverage, and in fact, about a third of families were hitting this stop loss, so it was quite binding. And once again, there's compelling evidence here of moral hazard, that spending is lower when consumer cost sharing is higher. When consumers have to pay a higher share of the costs out of pocket, they spend less. So again, just one example from this large experiment. If you look at people assigned to the plan with 95% consumer cost sharing, so they have to pay 95% of their medical costs up to the stop loss, you find that their annual spending is almost 2/5 less than the annual spending for those assigned to the free care plan. So again, as I said, this is compelling evidence against this null hypothesis of no moral hazard effects. So what does this mean? I think thus far what I've hopefully convinced you of is that contrary to what uninformed readers of The New Yorker might believe, moral hazard in health insurance is not a myth. There's really compelling empirical evidence that when you give people health insurance, they consume more medical care. When you give them more comprehensive insurance, they consume even more medical care. But key challenges remain for policy, and this goes back to what Arrow talked about in his original article, which is what are the policy implications of this? In other words, one question that comes up is how do you translate these experimental treatment effects, these differences in spending across plans that we see in the RAND experiment, into economic objects of interest? Or in particular, something that we're always very interested in is how would you take these estimates from the RAND health insurance experiment of these various plans and what people spent and use those to forecast out of sample the likely effects of different plans or different policies that we might be considering today. And that's really what I want to talk about in the second half of this talk. How to translate the economics of moral hazard into policy. And what I want to do is discuss several key conceptual challenges that you're immediately confronted with if you try to predict the spending effects of alternative health insurance policies or health insurance regimes, some of which I've been working on for the last few years. You can think of this a number of different ways. You can think about it in the context of current healthcare reform. I think often it's helpful just to have a specific example to ground discussion and focus ideas. So what I'm going to talk about is the introduction of high deductible health insurance plans. This was encouraged by the 2003 Health Savings Accounts Act. They basically encourage people through tax subsidies to buy plans that have very high deductibles. During the deductible, you're paying 100% out of pocket, and these have deductibles of up to $3,000. But then the idea is you get catastrophic coverage for expenditures beyond that deductible. So you're insured against really large expenditures, but the first amount you have to pay out of pocket yourself. And perhaps not coincidentally, that design is actually, again, going back to Arrow's paper, that's sort of theoretically the optimal design of a contract when you have risk-averse individuals and concerns about moral hazard. And in fact, one of the concerns of this was precisely to deal with moral hazard. One of the goals of this legislation was to get people into high deductible plans to reduce the level and growth of health spending while still providing catastrophic coverage that's so valuable to risk-averse individuals. So there are at least three questions that come up when you want to think about how a high deductible health insurance plan is going to affect health spending. One is which price matters to the consumer? Is it the deductible that they face at the start of the year, or their anticipation that by the end of the year they may have spent past the deductible? Which are they going to respond to in their spending behavior? Another question is who's going to select the high deductible plans, and how's that going to affect the impact of these plans on spending? And the third is why would health insurance affect spending growth, which is really the key problem as opposed to just the level of health spending. So thinking first about the first issue, what price matters to consumers, typical plans, and including those in the RAND health insurance experiment and also in the real world, both then and now, are highly nonlinear, which means that instead of facing a linear relationship between your total medical spending and your out-of-pocket costs, you more face something like what's shown in the red graph, which is that initially, you're in the deductible range, and so that's a 45-degree line there, or at least it should be. You're paying 100% out of pocket, and so your out-of-pocket spending is rising 1-for-1 with your total spending. At some point, you spend past your deductible, you hit a co-insurance arm where you may face, say, about a 20% marginal price, so your out-of-pocket spending is rising, 1/5 for every dollar you spend, and then at some point you hit the stop loss, that's the horizontal line, and now your out-of-pocket spending doesn't move with your total spending, and medical care is now free. And so one question is, at the beginning of the year, because these plans reset every year, when individuals are faced with a deductible, do they think that the marginal price of going to the doctor is the full price, the 100% that they have to pay out of pocket, or do they think about the fact that by the end of the year, maybe they'll have had a bunch of illnesses anyway and be past that deductible? Which price do they respond to? And that's obviously going to have implications for how much of a spending reduction you're going to get for introducing a high deductible plan. If people react as if the price is the spot or sticker price of 100%, they're going to reduce spending a lot more than if they forecast that by the end of the year they may face a much lower effective marginal price. In particular, if individuals are myopic, they might respond to the introduction of a deductible as if their price is increased dramatically to 100%. On the other hand, if you have fully rational, forward-looking, and not liquidity-constrained individuals, they may recognize that the spot price should not affect their consumption decision, only the end-of-year price. In particular, imagine someone with a $3,000 deductible, but who has a chronic condition that regularly costs over $10,000 a year. At the beginning of the year, if they have a headache and they're considering whether to go to the doctor to get this unusual headache looked at, they shouldn't be thinking that costs the full cost of the doctor visit. They should think, over the course of the year, I'm naturally going to spend past the deductible anyway and face a marginal price much lower, perhaps zero, of going to the doctor currently. The question is, do they do that? So this is something I've tried to get at in a recent paper with Aviva Arendine, who's a terrific graduate student at MIT, and my collaborators Liran Einev and Mark Cullen at Stanford, where we asked the question, how important is forward-looking behavior in moral hazard? And like the question of whether moral hazard exists in health insurance, the question of how forward-looking people are in their medical consumption is ultimately an empirical question. And so the key empirical idea that we take advantage of in this paper is that in employer-provided health insurance, the annual deductible resets on January 1st, regardless of when the employee is hired. So whether you're hired in March or in October, your deductible is going to reset in January. And so as a result, you have people who face the same, if you imagine someone who's hired into a deductible plan in March and someone else who's hired in October, they both face the same initial spot price of medical care of one, right? They have to pay fully for the first doctor visit, but they face very different expected end-of-year prices because the guy hired in February or March has the whole year to have health shocks accumulate and push him past the deductible, while the guy hired in October or November or December 31st in the extreme is very likely very unlikely to get past the deductible. So the basic idea is to use the variation across employees in hire date to look at a bunch of people who face the same initial or spot price for medical care, but different future prices, because guys hired late in the year face higher end-of-year expected prices. And then because, of course, guys hired in February may be different than guys hired in October, and the onset of illness can be different in February. The seasonal flu is unfortunately about it in March too sometimes, in April, and less so perhaps in October. We're going to use initial medical use for those hired into a no deductible plan, which doesn't have this feature, just to control for seasonal variation in hires or medical spending. And so what we find is we reject the null of complete myopia, the hypothesis that individuals respond only to the spot price. We find that individuals hired earlier in the year, so these are individuals who face the same spot price but a lower expected end-of-year price, initially spend more, so they're more likely to go to the doctor in the first month or two than individuals hired later in the year. So that suggests that individuals aren't completely myopic. They don't just respond to the sticker price. So there's some degree of forward-looking behavior, but how much and how important is it? So we use a simple model, which in the interest of time I won't go into the details on, in which we find that individuals are not fully forward-looking, so they respond both to the spot price and to the future price. And what are the implications? Well, so with the amount of forward-looking behavior we estimate, we find that the spending reduction of moving from a no deductible to a high deductible plan is a lot lower, about 25 to 50% than you would predict if you thought that individuals were fully myopic. Now the sign of that is obvious, right? As I described, when individuals are fully myopic, the deductible has the most bite because they keep thinking as long as they're in the deductible range, that's their effective price. But the magnitude, I think, is quite important, and we wouldn't have known without this estimation. And just to give you some context, and also to talk about a little more about why it's challenging going from the experiment to these policy implications. So the RAND investigators in their original work of course, we're aware of all these issues and tried to translate these differences in spending across plans into a prediction for how spending would respond in other plans. And this estimate, this famous -0.2 price elasticity of demand estimate, is widely used by the Congressional Budget Office and by many others, but they computed it under the assumption that individuals were fully myopic. And if in fact that's not the case, the spending effects of some of these plans may be a lot lower than we thought. A second and related issue comes to the question, if you're introducing a high deductible plan, who is going to select it? And in general, we tend to think of selection and moral hazard as distinct issues. So adverse selection is the idea that people vary in how sick they are, and sicker people are going to demand more coverage. We talked about that already. This moral hazard literature has tended to ignore heterogeneity and just focus on average price sensitivity, or the average slope of the demand curve. But one observation we started with is that people may differ not only in their health, but also in their price sensitivity of demand. And then you have to think about who's going to select these high deductible plans. Are they going to be the guys who are more or less price sensitive? That gets to this notion of what we call selection on moral hazard. This is another paper with my collaborators, Laurent Inev and Mark Cullen. This is also with Paul Schrempf and Steve Ryan. And so here we thought about a model in which there are three reasons that people might demand health insurance. One is the traditional adverse selection model that Joe pioneered, which is that the person knows he's high risk. In this case, he knows that he's sick. Another is what we've called selection on moral hazard. The person knows that he has a high price sensitivity of demand. If you make healthcare cheap, I'm more likely to use a lot of it. And then the third, of course, is just risk aversion. More risk averse people will always demand more insurance. Just maybe an analogy will help you. It certainly helped us sort of think about the difference between traditional selection and selection on moral hazard. And that's to think of, for a moment, outside of health insurance to the context of all-you-can-eat restaurants. Right? So in the context of an all-you-can-eat restaurant, traditional selection is that people with big appetites are more likely to go to all-you-can-eat restaurants. Right? Selection on moral hazard is the idea that even if you have an average appetite, if you know that when the marginal price of an additional entree is free at an all-you-can-eat restaurant, you're going to consume a lot more than you usually do when things are priced a la carte, that you'd also find an all-you-can-eat restaurant appealing. Right? So it's selection on the slope or the sensitivity of demand rather than the intercept or the level of demand. So we looked into this using data from Alcoa, where we had employee health insurance options, choices, and medical claims, and we found evidence of this notion of selection on moral hazard. The particular sign of it was that individuals who are higher moral hazard types, so these are individuals who increase their medical consumption more when it's subsidized more, so a higher price elasticity of demand, are more likely to choose more coverage. And quantitatively, it turned out to be quite important. Selection on moral hazard is almost as important as traditional adverse selection, at least in this context, in determining people's plan choices. So why do we care? Well, again, let's remember the goal, which is to translate these experimental estimates of when we randomly assign people to different plans, how does their spending change, into a forecast, for example, of what happens when we offer these tax-subsidized high deductible accounts. And the key difference is in most real-world settings, including the health savings accounts one, people get to choose whether to be in a high deductible plan or not. We don't randomly assign people to the plan. And so the traditional approach when we've tried to forecast how health spending is going to respond to introducing high deductible plans is to estimate, well, we think maybe 10% of the population will take up these plans given how they're priced, and then let's apply the average estimate of moral hazard that we get from experimental variation as in the RAND. And remember that experimental variation was key to get the causal effect of your plan on your spending. But here the very feature that's solving your causal inference problem, namely random assignment, is shutting down this possibility of endogenous selection, which can be very important. In particular, consider, for example, you're trying to predict the spending reduction associated with offering a $3,000 per family deductible plan. So we do this in the paper. And so that if you do the traditional approach and you assume that the people who are buying those plans are random with respect to their moral hazard type, so you apply an average moral hazard estimate, you're going to get that on average, if you go from the current plan to a high deductible plan, spending per employee will decrease by about $350. However, if you recognize, based on our estimates, that the people who are going to select the high deductible plan, that's less coverage, are precisely the least sensitive, price-sensitive people, the low moral hazard types, the spending reduction you're going to get by these people moving into a high deductible plan is going to be much lower because there's a low responsive type. And so depending on how you've priced the plan, the utilization effect, the spending decrease can be lower by a factor of 2 or 3. So this can have really important implications for how introducing a plan when you actually give people choice, as we usually do, is going to reduce health spending. All right, the third and final thing I wanted to talk about is really, in some sense, the key issue in healthcare spending, which is not the level of healthcare spending, but the growth of healthcare spending. So thus far, what I've discussed is that the likely effect of introducing a high deductible plan on the level of spending. And I've suggested that you may get much less of a spending reduction than you would have conventionally assumed, both because people are forward-looking in their medical consumption decisions, so they don't respond fully to just the current deductible, and because of this issue of selection on moral hazard. The people who choose the high deductible plan may be those who respond least to the deductible. But as I said, the real story in the healthcare sector is not the level of spending so much as its growth, especially relative to GDP. This graph, unfortunately, only goes through 2002, but it shows that basic pattern I put up in the beginning, that health expenditures as a share of GDP were about 5% in 1960. By 2002, they were about 15%, and today they're about 17%. So they're growing really, really rapidly as a share of GDP. What's behind the growth of health spending? I'm not going to spend a lot of time on this. Joe Newhouse and others have done work on this, looking at what the role of, say, the aging of the population or other sort of demographic factors could be. And while that all plays some role, there's widespread consensus. I think, after the gains from free trade, the next thing economists most agree on is what's behind the rise in healthcare spending, and it's a technological change in medicine has played a critical role. The introduction of new drugs, machines, techniques, et cetera, that weren't around 40 or 50 years ago. So that's what's behind the growth in health spending, but as Bob Solow taught us, we call technological change a residual, right? And what we really want to know is what's driving that residual, right? What's driving technological change in medicine? And in particular, what role might insurance play? So another way of saying it is, thus far, all of the analysis has been, how does my health insurance affect my medical spending, assuming that nothing else around me changes, that the healthcare system is held constant, or what we call partial equilibrium analysis. In fact, major expansions of coverage may affect the overall practice of medicine. For example, they can affect the incentives to develop and adopt new technologies, and therefore have general equilibrium effects on the healthcare sector that are very different, perhaps bigger or perhaps smaller, than these partial equilibrium effects we've been talking about so far. And this is something I studied in an earlier paper looking at the introduction of Medicare in 1965. So prior to the current healthcare reform, assuming it goes into effect, the introduction of Medicare was the single largest expansion of health insurance coverage. It provided health insurance to virtually all Americans aged 65 and older, and previously about 3/4 of those people, the elderly, were uninsured. The elderly were about 10% of the population. So just to give you a sense of magnitude, Medicare provided insurance coverage to about 7.5% of the US population, which is roughly similar to what the uninsured were in Massachusetts prior to the 2006 Massachusetts reform. The Affordable Care Act would cover about 11% of the population. So the expansion is roughly similar in magnitude. And so, to get at, what the effect of Medicare is, you don't want to just look at sort of time series what happened to health spending, going back to that graph I showed you, because of course other things are going on that can be driving healthcare spending. So instead, what we did in this paper is to notice that prior to Medicare, rates of health insurance coverage were very different across different regions of the country. So for example, if you look at the percent of the elderly who didn't have insurance, who would be newly insured by Medicare, in New England, you're increasing the fraction with insurance by about 50%, but in the East South Central United States by 90%, because many fewer of the elderly had health insurance. On average, about 1/4 of them did, but it varied a lot across region. And so you can look before and after the introduction of Medicare in areas where Medicare had more or less of an impact on insurance coverage, and look at differential changes in the growth of health spending. And so what you find are enormous spending effects. So, by 1970, and that's only 5 years after Medicare has come in, you find that hospital spending is almost 40% higher than it would have been absent the introduction of Medicare. And one sort of extrapolation you can do based on this is that the spread of all insurance, public and private, that occurred between 1950 and 1990 may be able to explain half of the six-fold growth in real per capita spending over this time period. So insurance is playing a very big role in driving healthcare spending growth, and this is contrary to what you would get if you use, say, the RAND estimates, which are partial equilibrium estimates, where you'd think that the spread of health insurance has explained maybe only a tenth of the growth of healthcare spending. So what's the difference? Well, one difference is that in RAND you have a real randomized experiment. You can be pretty sure of those numbers, whereas I had to do my best to compare these different areas of the United States and control for different trends. So, there's always a possibility that that's part of what's going on. But I actually think, and what I have evidence for in the paper is also what's going on, is that in RAND, it's 6,000 people across the United States. You're getting the effect of someone newly having insurance on their consumption, but the doctor they're seeing, or their medical spending, the doctor they're seeing and the hospital they're seeing is not doing anything different. However, when you suddenly have 7.5% of the population, and it's the highest spending, the elderly, newly insured, that's increasing aggregate demand for healthcare in a way that can provide incentives to change the overall practice of medicine. And in fact, I find evidence that Medicare encourages the adoption of new medical technologies. Remember, I said that it seems pretty clear that technological change in medicine is what's behind the growth in healthcare spending. And now you see that when you have large-scale insurance changes, so that there's a big aggregate increase in demand, hospitals now have an incentive to adopt new medical technologies that now people will use because they're not paying for them out of pocket. They wouldn't have presumably used them as much when they had to pay for them out of pocket. And you can trace that line of reasoning back further, not just how insurance affects the adoption of new medical technologies, but how it affects the development. That's harder to do in the case of in the case of Medicare, because it's a national or global innovation market. But other work that I've done and that Daron Asmoglu and Josh Lin have done looking at pharmaceutical innovation has shown that when you increase the expected size of the market for a particular drug or a vaccine by requiring that people get it, or subsidizing it, or by having a growing demographic base for it, you see increased new clinical trials and increased new drug approvals for drugs for which there's higher demand. So it looks like insurance, by increasing demand because it lowers the price of medical care, encourages both the adoption of new medical technologies, as we saw in the case of Medicare, and also further down the pipeline, actually, the innovation and development of these new technologies. Or another way of saying this is we usually think of insurance as providing insurance against current expenditure risk. But part of what insurance may be doing is changing the nature of expenditure risk that we'll have to insure in subsequent generations. So just to briefly conclude, going back to where I started, in 1963, Ken Arrow proposed the concept of moral hazard in health insurance, this idea that health insurance may increase the demand for medical care. And that creates a fundamental tension for health policy that's trying to both cover the uninsured and simultaneously reduce the level and growth of health spending. And the challenge posed, in this paper to subsequent generations of economists was, could we verify that this theoretical notion of moral hazard in health insurance actually existed? Can we quantify its magnitude? And can we explore its nature and implications for alternative policies? So how have we risen to this challenge? Perhaps I should leave this to my discussants to comment on, but I'll give you my take. I think there's compelling and really irrefutable evidence from randomized trials that health insurance affects medical spending. So those who say otherwise, whether in the pages of The New Yorker or elsewhere, I think basically are ignoring the evidence at their own peril. This is a fact of life. It may not be what we wished for, but we have to think about it and grapple with it and think about its implications for policy. Some of the implications have to do with what price the individual considers. Is it the spot price? Is it the end-of-year price? I talked about this in the context of high-deductible health insurance accounts, but you can also think of this in terms of Medicare Part D, the prescription drug program for the elderly, and the famous donut hole that's been talked about, which is a range of spending in which suddenly your price goes back up to 100%, and how the elderly are going to respond with a policy with a donut hole depends on whether they're thinking about it at the beginning of the year or not. Also issues of selection on your moral hazard type, and how health insurance may affect the development of new technologies. So I think we've made some progress, but naturally important questions remain. Let me just mention two of them, although I'm sure there are many more. One is, where does moral hazard come from? How much of it comes from the patient and how much of it comes from the doctor? right? So clearly, the decision to go to the doctor initially is primarily driven by the patient, but once there, how much of the decision of what care to get and how we should adjust that based on your insurance coverage is driven by the patient or the doctor. That has implications for designing contracts if you want to sort of reduce excess moral hazard. And another key issue comes down to the welfare cost of moral hazard. So the price of medical care does not reflect its true marginal social cost. So as just one example, consider prescription drugs, which by patent have prices that are much higher than marginal cost. The marginal cost is approximately zero. So it's not obvious what the welfare cost is of increased consumption of an already developed product. It may be the incentive to develop it in the first place. Another issue is how much of the response to the price comes from the substitution effect of a lower price versus the liquidity effect of actually providing income or liquidity in the state of the world when you're sick. And that obviously has implications as well for the welfare analysis. So hopefully, having learned what we could from Arrow 1963, hopefully Arrow 2012 will provide some new guidance for the next generation of research.
Thank you, Amy, for that wonderful exposition of the issues of moral hazard. Our first discussant is Jonathan Gruber, who is also professor of economics at MIT and co-director of the healthcare program at the NBER. He's been involved in health economics for a very long time, won a number of awards in that. And he also served as Deputy Assistant Secretary for Economic Policy at the Treasury Department. He is described, I don't know if he's going to admit this, as one of the key architects of Obamacare, which is known as Massachusetts healthcare reform efforts, which, as all of you know, was the prototype for Obamacare. I would say the prototype of Obamacare, which is for Obamacare. And he's been involved in public policy and look forward to his comments.
Thanks, Joe. Thanks very much, Joe. It's interesting time you mentioned Romney. Apparently, we have a competing speaker, Herman Cain, apparently speaking in the rotunda. And for any of those of you who would suggest leaving to hear this former CEO of Godfather's Pizza, I'd suggest you should stay because we have the godfather of health economics here. So I think that's a better bet for your money. I'm thrilled to be here to honor my colleague, Amy Finkelstein. I remember diligently working to recruit Amy to come to graduate school at MIT when she was on the Council of Economic Advisors in the late 1990s. And I would like to think that Amy's MIT education is responsible for some of her enormous success since that time. But to be honest, we're probably just riding on her coattails. And these coattails are indeed impressive. As some of us know, but many of you may not, Amy's gone on to become one of the best health economists in the country, as well as one of the best overall applied microeconomists in the country. In dozens of innovative articles that we just got a sample of here today, Amy has managed to really, I think, carry on this great MIT tradition, starting early on with Bob Solow and Paul Samuelson, working through Paul Joskow and many others in our department, of combining rich theoretical insights with compelling empirical work to really bring together the whole package. And I think you got a taste of that today. Now, after many years of watching Amy's career skyrocket, I was fortunate enough a few years ago to actually be able to co-author on a project with Amy, the study she mentioned of the randomized health insurance trial in Oregon. So I could see firsthand how she works, and I guess I have to use the term co-author quite loosely. The image you should have in mind is of someone sort of hanging onto a rocket as it zooms off into the stratosphere. I'm the hanger, she's the rocket. And basically that's sort of what co-authoring with Amy is like. I would receive literally dozens of emails a day, so fast that I couldn't respond before I'd get another one. And eventually I basically just dropped out, and she was kind enough to continue to keep my name on the paper, but I'm still shuffling through the emails years later. So it's really just a pleasure and enormous privilege to get to work with Amy on a project. Now, Amy's lecture tonight focuses on one of the key health information asymmetries. Actually, it's sort of ironic because in many ways, when we think about Ken Arrow's 1963 article, the first thought that comes to mind is not the moral hazard contribution, but the adverse selection contribution, and the notion of insurance market failure to adverse selection. And what's also ironic is that Amy could have done an entire lecture on the adverse selection issues. Her sort of has many years of contributions, including probably the seminal empirical article on adverse selection in the last couple decades. Her work with Kathleen McGarry showing how you think about adverse selection, the presence of both virtuous and vicious selection. So it's kind of a real compliment to Amy that she could actually take on a second key element of Ken's article and talk about moral hazard. So what I'd like to do is just make 4 complementary points to what Amy talked about, really coming back a bit to what she touched on in the end. The first is that she only focused on one kind of moral hazard, what she called the ex post moral hazard. Now she mentions also ex ante moral hazard, the notion that people might not take care of themselves because they're insured. I think this is kind of one of those things economists like to spend a lot of time on. It doesn't really matter very much. We actually did investigate this in the Oregon experiment and looked at whether people, when they had health insurance, would, for example, smoke more or exercise less. So far, we don't have any evidence that that's the case. And I think this is really kind of a cute point more than an important point. But there's another kind of moral hazard that Amy just mentioned briefly at the end that I think may be even more important than the one she discussed, which is provider-side moral hazard. Now, let's be clear, this is distinct from the general equilibrium effects Amy talked about in her Medicare work. Amy talked about her exciting work about how when you expand health insurance to some people, that propagates through general equilibrium effects. This is a separate issue. This is the issue that is really summarized best in some quote. It's either got to be due to Winston Churchill or William Shakespeare or Oscar Wilde, because they said everything. But it's some quote which is sort of saying that having the doctor tell you how much medical care to get is kind of like having the butcher tell you how much red meat to eat. And that we have this broken fee-for-service healthcare system where physicians are paid and providers are paid based on how much care they deliver, not on how healthy they make you. And this is really the focus of most discussions of healthcare cost control today. While many of us are fascinated by individual side moral hazard, in fact, most of the discussion that dominates policy circles is not about that. It's about the provider side moral hazard and how can we move from our existing fee-for-service system towards things, for example, like accountable care organizations, where providers are brought together under one global reimbursement system and reimburse some aggregate amount based on enrolling you, not actually how they treat you. Now, there's a huge amount of evidence that provider-side moral hazard matters. Probably the most compelling example was also from a big change in Medicare. Probably the biggest change since they introduced the program in 1965 was in 1983. Medicare led the way in moving from a fee-for-service reimbursement system to a prospective reimbursement system, where they paid hospitals not based on what the hospitals did to you, but based on what was wrong with you. And when they did so, there was an enormous change almost overnight. Within a year, the average length of stay of the elderly in hospitals fell by 15% within 1 year. And yet, there was no effect on elderly health. That basically we were delivering all this excess care that was not improving the health of the elderly, and we could get rid of that, save a lot of money, and lower utilizations. This is a really important part of moral hazard. It's not in any way to dispute what Amy said, but it does raise a critical issue she raised at the end, which is the complementarities between the patient-side moral hazard and the provider-side moral hazard. And in some sense, these communities are kind of not talking past each other, because if you talk to the provider-side moral hazard folks, they say, oh, that patient-side stuff's not important. It doesn't really matter. Co-pays, deductibles, that's all just regressive and unimportant. We've just got to focus on how we reimburse providers. And then you have other folks, I'm more on the other side, saying it's really critical that we get consumers to be more cost-sensitive and paying attention to the cost of medical care. Both sides are clearly right. And what neither side has really tackled, and someone like Amy is ideally positioned to tackle, is to think about how they interact. And in particular, how do we interact the provider side incentives with the patient side incentives? How do we, for example, set up patients in plans which charge you more if you go to providers that are on fee-for-service, not on capitated reimbursement, et cetera? How do you put these two things together? And I think that's a really critical issue to think about going forward. The second issue is the interpretation of the evidence from Rand and Oregon. Amy mentioned this a bit at the end, which is what these studies do is they do not measure moral hazard. Okay? What they measure is the effect of price on medical care utilization. And that consists of two components. As economists, we think of them as income and substitution effects. But more generally, we think of them as the fact that on the one hand, the price of medical care is changing. On the other hand, when you have insurance, you've just been given a gift of money should you get sick. And you may choose to spend some of that money on your treatment. And that is not a distortion in the system. That's just how you choose to spend your money. And this is what we call liquidity effect. That partly what's going on with what's going on when we give people more health insurance and they spend more is that people would always like to spend more medical care. They're constrained from doing so. By giving them money when they're sick, we allow them to afford that expensive operation they couldn't otherwise. And that's not a distortion in our system. That's just getting rid of a problem that people face liquidity constraints in our system. Now, the problem is these have very different policy implications, these, whether it's the true moral hazard or liquidity effect, and we don't really have great evidence to separate them. In fact, in other contexts, in the context of unemployment insurance, Raj Chetty at Harvard and his colleagues have done very exciting work showing that a lot of what we thought was moral hazard in unemployment insurance is actually just liquidity effects. So we thought, gee, there's this evidence that if you give people higher unemployment insurance benefits, they stay unemployed longer. And people like myself have been running around saying, well, that means unemployment insurance is too generous, and we give people these unemployment benefits, they sit on their couch. Well, they did a great study. They looked at Austria, where they didn't give unemployment insurance benefits, they just gave them severance payments. So you weren't paid based on how long you stayed employed, you just got a check when you left your firm. And you know what? People stayed out of the labor force just as long. They still just sat around on their couch. And the point is that people seem to value sitting around their couch, and that basically the liquidity benefits of these grants were mattering as much as the moral hazard effects. And I think really thinking about that more in the context of health insurance is critical. Really, we know the ideal experiment to run. You'd like to take two people, one you give health insurance, the other you just give them a check should they get sick and say use it any way you want. And you ask, do they behave differently? If it's moral hazard, they'll behave differently. If it's just a liquidity effect, they'll behave the same. I don't think we're going to ever get to run that randomized trial, but I'm sure Amy's clever enough to figure out a way to tease out that test in the real world. My third comment is that to think about, if you listen to Amy's talk and think about these moral hazard effects, it seems pretty obvious that we ought to have patient-side cost sharing. We ought to have patients bearing some of the consequences of their medical decisions. Well, there is, of course, a flip side to that, which is affordability concerns. Why are many people opposed to having patients face cost sharing for their health care? And it's really affordability concerns. They're worried that people can't afford these costs, and that's why we have out-of-pocket limits, to make sure it's affordable. But if you take a very poor person, someone at the poverty line, individual with an income of $13,000 a year, they can't afford a $2,000 deductible. They probably can't afford a $1,000 deductible. This is not something that's really affordable for them. And really, and years ago, actually, Marty Feldstein proposed a plan. He chose the unfortunate acronym. He called it Major Risk Insurance, or MRI. That was sort of an unfortunate acronym given medical developments in later years. But his major risk insurance plan was people would pay 50% of the cost of their health care until they'd spent 10% of their income. This is actually, I believe it may be Marty Feldstein's only progressive policy proposal. And that basically, what it said was that basically people be protected from being bankrupted by medical costs, but be price sensitive on the margin. Whether that's a good idea or not actually depends on another aspect that hasn't really been studied, which is the income heterogeneity in the kind of moral hazard Amy's talking about, which is whether that's a good plan or not depends on, are poor people more or less sensitive? So if you protect poor people, but they're really super price sensitive, then that might have a higher welfare cost. You might want to not quite protect them as much as we otherwise would. So we've got to understand not just the overall moral hazard effects that Amy mentioned, we've got to think about how that affects differ along the income distribution, think about setting up the optimal kind of major risk insurance system. Finally, I want to mention one other point, which is to think about another difficulty in translating Amy's work to policy is the trade-off between setting the right marginal incentives for consuming health care and certainty. So economists have always said that the right way to set up a health insurance plan is to have what we call co-insurance, which is to say that you would pay X% of your bill, 20% of your bill, up to, say, some maximum. Okay? People in the real world hate co-insurance. I mean, now I'm in sort of this policy world, hate co-insurance. They like co-payments. And we ask them why, they say because it's too uncertain for people going to the doctor, they don't know what they're going to pay. Now, part of that is the lack of price transparency. We don't know what 20% of a doctor's bill is going to be because it's not posted. But part of it is true uncertainty, which is you don't know what that doctor's going to do to you. And you don't know, you're going to go in, you know which tests you're going to get, et cetera. And that subjecting people to co-insurance subjects them to some uncertainty. And we know from the pioneering work of Ken and others that people don't like this uncertainty, okay, that they would pay to insure against it. And that actually raises a really interesting question of what's the right way to incentivize people. The next step in Amy's research agenda can be what's the right way to incentivize people, given this trade-off between, on the one hand, you want them to face the price on the margin. You want co-insurance because that stops them from getting the really expensive treatment. On the other hand, that introduces more uncertainty into what they're going to have to pay out of pocket. I think a really interesting question that is straight along the line of Amy's research agenda is to understand those trade-offs between coinsurance, which economists find appealing, and copayments, which people in the real world find appealing, and how we actually kind of resolve that trade-off going forward, I think is really important. So that's just a few sort of ideas for, you know, Amy's work is uncriticizable because it's so excellent. So rather than sort of try to do the impossible, I thought I would try to sort of offer a few suggestions for what's going to go next, and I think Amy's really perfectly positioned to do that. I want to close by saying how thrilled I am, how wonderful I think it is that she was selected to honor Ken Arrow's work, and she's just a terrific example of watching someone's work continue to evolve and improve, and it's just exciting to have a front row seat for that ongoing process and to see that happen. So thank you very much.
Thank you very much, John. And one of the wonderful aspects of the Arrow lecture is that Ken has graciously agreed to always comment on the talk, and that always is an exciting moment because it both reflects how he thought about the problem many years ago and how he's thinking about how the debates have evolved over the subsequent decades.
Thank you very much, Joe. That kind of introduction always is a long time, and I don't expect that to be correct, but we'll continue for a few years. I'm very happy, of course, to be here in my old alma mater, my graduate alma mater. I don't know what the proper phrase is. And it's a very different world in many ways, both in the university, the kind of what was taught in economics departments, and what is the issues that we are concerned with have evolved. Although, I must say, the Great Depression does seem to have a rather contemporary echo, which is so I don't know that some things changed some around in cycles. We've heard a wonderful speech and a drawing together of evidence, the ability to develop experiments and to exploit natural experiments with a creative emphasis on the theoretical understanding. I think we've heard from Amy has been a great pleasure to all of us. We've had the papers before, but this puts the whole thing in a perspective that is bound to that is already making a contribution to our study of our health problems. I want to let me take a tack which was referred to by Amy as spoken somewhat length about by John, which is I might call the non-economic side. In fact, this is part of this is in my original paper. Let me go into the concept let me start by talking about what moral hazard is and a little bit of its history. What I meant by moral hazard basically is an asymmetry of information, an asymmetry of knowledge between two parties. A moral hazard is one kind of asymmetry. Let me make it clear. It's not the whole concept. What really struck me, let me say perhaps a word about the origin of this project. The Ford Foundation then was a very large grantor to research in the social sciences. And one of the officers there was Victor Fuchs, who many of you know is one of the most distinguished health economists in the country and the world. I had met him, but I didn't, we didn't all close. I get a call. He had the following project. which had gotten approval from the director of economics research, I think it was Lloyd Reynolds, if I remember correctly, of Yale. He wanted to take 3 issues of which involved public and private policy, and have each one studied by 2 people. One person who had already worked in the field and would give some kind of summary, and another would be preferably a theorist who hadn't worked in the field at all and would see what theory could do. And he wanted me to be the theorist for health. I have a tendency, which has worked out quite well for me in many ways, to take a dare. This is probably the best example, although the social choice book actually arose to some extent in the same way. Namely, I'm challenged to do something which I'm not doing. I'm not continuing research. I think, well, this is more exciting. I'll learn something. And I thought, after all, if health is a serious issue, theory, if it's any good at all, you know, a point which can be debated, this would be a good place to apply it, see what we have to say. I very diligently read the various books, what literature existed. There were health economists even then. There was Ned Rorem, there was Harold and Ann Somers, a lot of descriptive material. I was, of course, my big interest had been the economics of uncertainty, apart from social choice. My big interest was risk-bearing uncertainty. And I was trying to fit it into a general equilibrium with uncertainty concept. And, you know, why can't we have health? Why can't we have much more extensive health? It seems to me, it seemed pretty obvious. If you have risks, you ought to have insurance. That didn't seem to be a great thing. Insurance, at that point, there was a fair amount of hospitalization insurance. It was just the beginning of insurance for what they called major medical risks, which is meant actually risks outside of the hospitalization area. It was all incipient. Although, as you saw from the graphs, the health problem, it looked pretty big then, but by modern standards, it looks trivial. It was probably, this was even before you started, it was probably 4%, well, it was the order of 6% of national income or something. So it was not it was a significant problem, but not overwhelming. Anyway, I was trying to fill it out, and I began to wonder, why? Well, there isn't health insurance because, after all, it's difficult for the insurer. I was thinking then of an insurance company, HMOs and things like that didn't exist. There were a few clinic groups, actually, but they were a very small part of the story. That they would be, what is the insurer insuring against? The idea is, I feel like, okay, if you have an automobile insurance, you have a smashed windshield, that's it. There's no choice involved, you have the windshield. Now, even then there are some problems of moral hazard, but they're not exactly the dominant item. But you're sick. Well, you get diagnosed, turns out you're sick from something. It's not what you thought it was something else, and maybe more expensive, less expensive. And a lot of decisions have to be made along the way, some of which are just questions of comfort, some of which are really medically significant. And the insurer is not in too good a position to monitor what's going on. This is interesting. Then there was on the other hand, there was this idea, of course, that insurance makes things cheaper. But you see, if what is being replaced, what is being done is pre-assigned, given the diagnosis, that's it. There's no moral hazard if you simply pay it. So I began to realize that and then I began to realize there was another problem, the relation between the physician and the patient. How does the patient know the physician is putting forth full effort? To take a case, which unfortunately I know some friends of mine had serious consequences from that, so it's not imaginary. And suddenly it occurred to me that these were the same issue. And it's just like the cartoon strips, a light bulb went up. I remember I've been reading all this stuff, spending several months trying to do a diligent job, and it was turning out to be a kind of a workmanlike thing where I said this relates to theory and why this is, and suddenly I got the idea there was a general principle here. And the general principle was that in these relations there was asymmetric information. That you're dealing with people, a doctor by definition, that's his function in life, is to know things you don't know. The insurance company is also at the mercy of the physician-patient. Okay, so then that raises, of course, first of all, an issue with relation to, with that concept of moral hazard. As opposed to the adverse selection was another example. Now, I had had some slight exposure to the actuarial world, namely, at one point in my life, not knowing what I was going to do for a living. Money was, my family was badly hit by the recession, by the depression. I was concerned with some secure occupation. Academic life was sort of another world. I didn't know about that. And so one thing I was thinking of becoming an actuary. I'd come across, in the reading, you came across words like moral hazard and adverse selection. But I wouldn't not have thought of them as part of my working knowledge, but somehow, though this probably had been like 10 years earlier, or more than that, 20 years earlier, it sort of came, suddenly I said, oh yeah, but this is what the insurance company people are always talking about. So anyway, this was the idea that asymmetric information was a significant part. Now, question is, how do you deal with asymmetric information? This is a defect. In other words, I had this system of ideal future markets, conditional on uncertainties. But of course, if there's an asymmetric information, you and I can't make a contract conditional on something if only I know whether it happened or not. So we have an immediate explanation of market failure. And what does this create? If you have prices for everything, ethical considerations don't really enter the story. But as soon as you have this asymmetric information and the failure of prices, you have some kind of things. There's some kind of ethical problems, which are, say, they're not, the true market system doesn't have it. You have some kind of a social benefit in ensuring truth-telling. And now, of course, there's a vast literature on mechanism design. Personally, I have the feeling while it's a very important literature and has some role, there are all sorts of reasons why this is not an adequate substitute for this kind of market failure due to asymmetric information. In some cases, it will be. Even in the financial world, where we've seen so much of this, I think it's very difficult to devise incentives. We know that we have some evidence that the incentives they have supplied haven't functioned as well as might be desired, if I put it delicately. It's not clear to me that there's any way of correcting that completely. Okay, let me stick going to medical care. One of the points that has been raised briefly by Amy and a little more extensively by John was that if we look at the system, the decision to buy medical care, to use medical care, is by no means a decision of the patient only. I rely on the doctor just as I rely on an attorney. There's a reason why professions have a special role. They're marked by strong inequalities in knowledge. What the doctor is basically what service he supplies is not skill, that matters, but knowledge. And you can argue why you have specialization. You can say if a person is acquiring knowledge is something that can be used over and over again. So it socially pays to have some people have knowledge and use that knowledge over and over again with new patients or new clients, rather than everybody being educated in the medical field, or when you get sick, you take a course in your illness. It's clear. But that creates automatically an asymmetry of information. The physicians, the hospitals, there's a whole system of which we say physician, but actually it's much more kind of the HMOs. And of course, this creates the thing. One of the immediate reactions of insurers when they started gradually going into this business was they would start checking on the doctors. So they have this business of doctors saying you should do something, and the insurance company rejecting it, which has gotten so notorious. So that you see, in other words, they're not they're using their knowledge. So you begin to get a very complicated kind of information system, which the patient's role becomes very minimal. And this is what worries me about some of the interpretation, and particularly the question, which is the most striking thing, of the differences in, what did you call it, the moral hazard response. Whether exactly what the source of that is requires, I mean, is it that you're getting different doctors, for example, or different localities with different traditions? So the fact is that medical ethics has always been considered a very important matter. I know that there's a whole school of thought, especially around the University of Chicago, or at least there was, the old, I shouldn't say contemporary, it's not contemporary, but the old, which argues that restrictions on medical, that medicine's based, all these rules and ethics are essentially devices for improving monopoly power. Milton Friedman was a great advocate of that point of view. And if you remember, he went so far as to argue that you shouldn't even license doctors. You should have free entry into the medical profession. And that was the breakdown. But I think it misses the point very considerably. We find, for example, medical associations putting out information designed to prevent you from getting ill, which presumably could hardly be regarded as profit maximization procedures. In my original article, I instanced the fact that doctors and hospitals don't advertise as an example of a signal that they're not financially. Unfortunately, that particular story is quite wrong. When I pick up the papers and I see very respectable hospitals explaining whether the best place to go to for Sloan Kettering is go for cancer or whatnot, I'm still a little shocked, but I suppose you people are not. But I'm saying we rely on ethical ethics to this, and that, after all, goes back to Hippocrates. This was always true, and similar things happen in other professions. Now let me mention some evidence. I'm not an expert, and some of these facts, some of these alleged facts may not be facts. I should say one more thing. The introduction of new medications and drugs, medications and devices, is always a question, a matter who decides. And one of my students was studying that and found that it was very hard to locate who made the decision. Every HMO would say, "Oh, it's up to the doctor. If the doctor thinks it's necessary, we buy it." But it's clear that some HMOs you don't want to do it. And it's that subtle kind of thing which isn't caught by the market system. Then we notice, for example, that the medical costs vary greatly by region, as the Dartmouth group has emphasized. And with apparently, as studied, has claimed no particular relation to outcomes. If you take international comparisons, of course, we have enormous differences in medical costs. After all, it's pretty much the same allocation problem. It's not at all clear why there should be this. I mean, Canada does not face different issues than the United States. Why is Canada so much cheaper? And as I say, most of the countries, if insurance jacks up prices, should for most of them have much better coverage than we do. So you should expect the thing to work the opposite way. You expect Canada to be more expensive than the United States or well, the British system is so different that I don't want to compare that. But the French system or the Israeli system or all these involve seem to be giving much greater coverage and yet somehow getting by with much lower costs. Nobody I think nobody's even close to the United States, I think. Now, it's widely held, at least, I believe probably correctly, although it's hard to prove these things, that if you take different HMOs, their costs are quite different. at least locally, everybody says Kaiser is much better it gives much better value than others. And yet Kaiser is not spread. That's interesting. In spite of efforts, they have not. It's not the workings of the market should imply that Kaiser and Kaiser-like plans should spread, and I believe they have spread, but not nearly as rapidly as one might expect. Now, an economist always hates to invoke the word or the concept of culture. Culture is more, it's been around, well, at least since Max Weber's identification of the emergence of capitalism with religion. Now, which is what, about 1905 or something like that. But in particular, on the other hand, we go to our business school colleagues, not our economics colleagues in the business school, but our organizational behavior colleagues, we'll find they're always talking about corporate cultures. Now, the idea is if you have an organization, people working together, they develop ways of working which are hard to change. If newcomers come in, they're going to be adapted to the culture rather than things. So the fact that other firms are doing better doesn't necessarily mean that it's now true in the long run. You'll eliminate the inefficient firms, but but especially in the medical field where competition, for various reasons, is not going to be so severe. We certainly do see big differences. We see differences even in firms much more exposed to the market. So what we clearly need to develop, and obviously there's room for, is a culture of for accountability, what is the word? Accountable care organizations. That's right. Accountable care organizations, or whatever, which have a culture of cost effectiveness. Now, how this is going to be achieved, I must say, is one of the mysteries. I don't really think that no amount of that. I think that playing with the contract, the reimbursement systems, going to capitation instead of fee for service, all these things matter a great deal. But I think there's going to be a lot more that has to be achieved by organizational claims. And now this, obviously, since organizations perpetuate themselves, it's going to need some kind of outside leadership, but not, I think, central control. Something like the British National Institute of Clinical Excellence, is that the word? Yes. National Institute of Clinical Excellence, which gives statements about the value of new drugs and with some idea of their costs is going to play some important role. Now, how this is going to be studied experimentally, I'm afraid I'm going to leave to those much more qualified than myself to discuss. Thank you very much.
Thank you very much, Ken. I've been asked to give a few comments. Let me begin by addressing, in a way, the most fundamental issue that we're all interested in is the design of a healthcare system, including an insurance system, that would increase our welfare. And when we think about this, one of the fundamental problems in the analysis is that in most other areas of economics, we begin with the presumption that markets are efficient. And this is an area where we should begin with the presumption that markets are not efficient. And that really changes the analysis in a fundamental way. One of the reasons that the markets are not efficient has to do with a very general theorem that Bruce Greenwald and I proved a number of years ago, namely that whenever there are information asymmetries, either of the adverse selection or the moral hazard kind, or incomplete markets, and those are assumptions that are always true, but are particularly true in the healthcare market, the economy is not efficient. It's not constrained Pareto efficient, taking into account the cost of information, the cost of setting up markets. There are always interventions that could make some individuals better off without making others worse off, make everybody better off. So the kind of doctrine that you hear on one side of the political spectrum, that if we just let it to the markets, everything would be right, has no intellectual foundation, that there really is a need for government. And that's why the issue of how do we design an appropriate set of institutions is absolutely key. The second observation I want to make really echoes what Ken was saying. Our current system isn't working. And to me, the issue isn't so much that we're spending so much on health care. I don't have a priori a view about the right amount that we ought to be spending on health care. People like to live longer, especially as they get near these boundary value conditions. And so it's understandable that people might want to spend a lot of money on health care. So it isn't that we spend 17% of our GDP on health care that's the problem. It's that we get so little for how much we spend. The real problem is the inefficiency of our health care system. The fact, as Ken pointed out, we spend much more than any other advanced industrial country, not only much more as a percentage of our GDP. Countries like France are 11%. I think that's the highest. Amy probably has the data. But anyway, 11%. And in terms of the actual dollars, it's about twice of what a number of other countries spend. And yet, our health statistics are worse than other advanced industrial countries. In fact, in some dimensions, in infant mortality, our health statistics compare with some developing countries. They're worse than Cuba. They're an embarrassment. Some of that has to do with the first issue that Amy talked about, the problem of access, that large fractions of America do not get access to adequate health care. I'm going to come back to that in a second. So one of the question that we ought to be focusing on, it's a little bit outside of Amy's talk itself, but I do want to raise, but it is part of the welfare analysis, is why is our healthcare system so inefficient? And again, the point that Ken raised is absolutely right. The people are not basic. It's not like Americans had this immigration where only sick people came to America. In fact, historically, we always talk about the selection effect going the other way. It wasn't the sick and the ill that came here, and the genetically defective. And it's not as if the weather here, on average, is that much worse than other places. There are places that are better, I know, but it's not the worst. So inherently, there's no reason why we should be having to spend so much to get so little. It's also clear, as Ken pointed out, information asymmetries are on both sides of the Atlantic and the Pacific. So it's not as if this is a uniquely American problem. A moral hazard, adverse selection, problems of doctors exist everywhere. And what is clear is that the way we have solved those problems isn't as good in some ways as others. Now, part of the reason I think has to do with old-fashioned rent-seeking. We have created some institutions that are very good at rent-seeking and do a better job at it than those in other countries, and we have in the public sector, less control. And so, not a surprise then that we wind up having an expensive healthcare system. You might say the symbolic, the emblematic of that, of course, is the provision in the 2003 Medicare drug benefit, where we said we couldn't negotiate with the drug companies. That's been estimated. That provision is estimated that the U.S. government, the largest purchaser of drugs, couldn't negotiate with the drug companies. Some people estimated that the cost is in excess of $50 billion a year. And that just added to that, to that number. That's a small example, but there are others. We had a Medicare program called Medicare Advantage that was basically identical to Medicare, but it was in the private sector and it cost about 20% more. And it didn't do anything better. You ask, why did we have it? Well, we had it because they lobbied to have, the health insurance industry lobbied to have it, and they made money. And, you know, transaction costs are a bad thing for most of us, but for the health insurance industry, they're a good thing because that's what they live off of. Probably even more as important as these is the other point that Ken pointed out, is that the practices vary across the country and across between countries, and there are many practices that are not cost effective, and for which you see that there are some places where they do things like toxolectomies and various things that are expensive, and for which there is no evident benefit. One of the good things that was in the Affordable Care Act was a provision for trying to do a more scientific study of these practices and hopefully create norms where you don't do things that cost things that don't yield any benefits, or at least begin a more scientific discussion of medicine. The other set of remarks I want to make has to do with the development of economic theory. I was very much influenced in my work by reading Keng's little book that he wrote, his Johansson lectures called The Theory of Risk-Bearing, as well as his paper on moral hazard. And these were really seminal works that began to help us think about problems of the economics of information, information asymmetries. And the underlying problem that all of these examples are, in the case of moral hazard, is that we can't observe the output. If we knew, and we can't observe the input. So that's a real problem. We don't know what the doctor is doing. We don't know what he should do, and we don't know what the consequences are, because even if he did the right thing, we could have a disease that will have bad outcomes. So we can't judge whether the doctor has done the right thing by whether we survive. He may have done the right thing and we die, and we may survive and he did the wrong thing. So it's really difficult to have pay by performance, and that's part of the inherent difficulties. But the models that I studied and that Ken studied and others studied some 30 years ago were always very simple. We looked at a single example of asymmetry of information, a single moral hazard, a single adverse selection. And what the discussion this evening has highlighted is that most interesting problems involve multiple information problems. Even in the moral hazard, the answer was there were two moral hazard problems. I said a double moral hazard. We don't. There's the doctor doesn't know the illnesses of the patient. The patient doesn't know whether the doctor is doing the right thing, and the insurance company doesn't know about either of those two. So actually, there are three moral hazard problems. But then in the insurance market, there's the additional one is of information asymmetries. The insurance company doesn't know what my health condition is, and I don't know whether the insurance company is going to pay me when I actually need them to pay. So that there is a problem of payment. What's striking to me is that in the ensuing years, there's been actually remarkable little research done in a theoretical level of trying to analyze models where there are these multiple information asymmetries. The reason is very understandable. The problems get very complex very quickly. One way of thinking about it is you have incentive compatibility constraints. You have one set, then you multiply that when you have another set, and you try to analyze how these interact simultaneously, and then you have adverse selection, and then they get very, very difficult. I've done some of that, and the only thing I can say about it, as far as I know, nobody has read it, because it's so difficult that even I struggle reading it after I write it. So the problem is the insights are not so clear. But what is clear is that the problems that we face at a practical level all involve these multiple levels of information asymmetry, so that in one way or another, eventually we're going to have to cut through and find what are the approximations, what are the right simplifications that allow us to analyze it. But it's great PhD material, thesis material, for those students who like to have complex problems that even their thesis advisors won't be able to read. We have time for a few questions now. There's a microphone back there. So go to the microphone. Run, because we have only a limited amount of time, and we don't have a price system working. Another market failure, but...
Thanks. The issues that are raised by Joe Stiglitz and Ken Arrow's comments, just to me that this business of, if you look on the face of it, the cross-country evidence argues against moral hazard in the sense that countries that have more comprehensive coverage have lower costs in terms of proportion of GDP and so on spent on health. So the question that partly arises there is then the problem, the moral hazard, not with consumers of healthcare, but providers of healthcare? And does that explain why this difference? Presumably the consumers of healthcare have similar behavior, whereas the similar incentives and so on. Whereas what is different in the system are the incentives for the providers of healthcare. And therefore, that becomes the kind of central, the hypothesis being that's where the problem lies and that's where research should be concentrated. Is that?
We'll take a few questions at a time so that we can, go ahead.
Oh, yes, thank you. A very interesting afternoon. I wanted to pick up on some of the comments by Professor Gruber and Arrow to ask Professor Finkelstein a question. There was no discussion about provider moral hazard, and actually patients only control in their demand about 10% of all costs. Most costs are in the hands of specialists in hospitals who have multiple profits and gains and incentives from ordering more tests and services for their professional well-being and their income. So in your studies, did you have a control and examination of the degree to which the increase in demand and cost to which you are attributing to individuals accounted for by providers?
Hi, thanks everyone. I'm curious, perhaps for Amy, but for anyone, as to how preventative care may come into some of these modelling around increased use and potential reductions in future spending. Thanks.
Same question. When I have health insurance, I go for more medical care, but a lot of it's preventive and supposedly it'll pay off down the line, and that wouldn't have been measured, or would it have been measured in the Oregon study and in the RAND study? Thank you. Great presentations.
Thank you. Can I just add a question? There were 2 points I wanted to make that I forgot. One of them is that normally, this goes to the welfare issue, normally we think of technological advance as a good thing. And there was a little bit of a hint at your saying that technological advances were driving costs, and since there was this paranoia about costs, a suggestion that it was a bad thing. And let me give you my answer, which is that some of the technology changes are actually good things. That they are extending lifetime and they are enhancing welfare, but that in fact the costs that we pay for it are not the marginal cost. There are large ranks associated with it, so that our system of producing technology is not efficient, and our system of using it, there, for instance, in some countries, you can only use more expensive drugs if you can show that they have a benefit. There are, what do they call them in Australia? there are lists, anyway, they have lists of drugs that you can use, and whereas we don't have those kinds of control mechanisms. And so in a way, while technology can have the potential for increasing welfare, the way we've used the technology and the way our market distorts the production of technology means sometimes it's not welfare enhancing. And the second point was really related to the last question. You've talked about, in your RANG study and a couple of the other Oregon study, you talk about usage, hospital admissions now, but that doesn't talk about long-term health care costs. If some of these people are going to the hospital today, would not have gone, but would have wound up with much worse diseases. That is to say, that the problems would have accumulated. It isn't obvious that more usage today is going to lead to higher healthcare costs. Okay.
All right, well, I guess there were really three sets of questions. So one had to do with moral hazard on the provider side and the role of providers versus patients. John didn't mention, but I'll mention, he's not only now my colleague at MIT, he was originally my thesis advisor at MIT, and I think his discussion in some sense embodied, what the ideal thesis advisor does. They encourage you, they tell you what you're doing is wonderful, and then as you're walking out the door, they make a side comment that basically very gently suggests you've entirely missed the point, but you leave feeling really pepped up and encouraged, and then, 3 days later you realize, oh, now I understand what I need to be working on. And I think his comments and the first two questions that came from the floor do really emphasize that, one of the key place we need to shine the flashlight now is thinking about incentives on the provider side, and not just the issue that I was alluding to of how much of the patient response is influenced by the physician, but how much of what the physician is doing is a response to their own financial incentives. And I think that's an area where we need a lot more work. The second question that came up on preventive care, so the first answer is, and sort of future healthcare spending that Joe brought up, we did look at this in Oregon, and the results from the first year show that there is increased use of preventive care, increased use of mammograms, prostate screens, checking your blood for cholesterol, et cetera. It's not, it's not clear that what the long-term benefits of these are. In the course of our study, the recommendations on mammograms changed, so I think there's some general medical, and so we didn't know how to code recommended preventive care, recommended as of when, right? I think, the question Joe raises about the long-term future spending is something we'd like to follow. We can't follow it in the experiment. The experiment itself lasted only 2 years, but we're getting physical measures of what happened to your blood pressure and your blood cholesterol and were you on your blood pressure medication, and we can use those to try to forecast, what the long-run health spending would be. John may have a different view. I have to say, I'm pessimistic that this will actually, in the long run, reduce spending, and in some sense, I feel that setting that up as an objective kind of misses the point, which is that it's okay to spend money on your health. And if health insurance increases health spending, that's not necessarily a bad thing. It would be nice if there was a free lunch and you could actually save money and improve people's health at the same time. I'm sort of pessimistic on that, but that sort of, again, relates to Joe's last point, which is a very important point to conclude on, which is, he said you talked about technological change driving healthcare spending, which suggests it's a bad thing. You can also put up a graph that shows that, survival, particularly for people 65 plus, has increased dramatically over the last 40 or 50 years, and that's also in large part due to technological change. So I think you're absolutely right that the question is not do we need more or less technological change, but how do you align incentives to get the socially valuable type of technological change. I'm a little less sanguine than you about the lists, in the sense that there are certainly some things that, we think almost everyone should do and some things that almost everyone shouldn't, but there's probably a lot of heterogeneity both in the treatment benefits and the preference benefits, and so it's hard to know how to work that out.
Great comments.
All right. Ken, do you want to?
Well, I must say, is this on? I guess it is. Okay? I have said to several people that the real way to control costs is to abolish the National Institutes of Health. And somebody said, puzzled, that only costs $50 billion a year. I said, that's not the point. It's all these expensive medications that result from this research. Obviously, we don't believe that. We do believe that the costs, there's this rather heroic calculation by Hall and Jones arguing that the idea that we should be spending 30% of our GNP on health is by no means absurd, considering they did some calculations of the benefits. It's all, the numbers are sort of made up, but they're not totally incredible numbers. That's the point. They are, but they're not. So, look, I think what's creating the health problem, why it's a special problem, is it's a matter of public interest. There's taxes are involved. If somehow we could do all this and insure, but do this all privately, but there's an interesting ethical judgment here that we don't like to see people die if the medical care is available, and the only problem is they're paying for it, even if it's their fault by not having insurance. We're aware of that. This is. Let me give a parallel. I'm sorry to extend this. A number of years ago in the Sierra Club Bulletin, there was a letter. It had to do with the fact that the National Park Service was proposing a rule that every climber had to have a helmet. And this fellow had been a famous mountain climber, was a manufacturer of the very high quality climbing equipment. Said he objected to it on grounds of freedom. That he said he understands the reason for it. If a person is injured, say trapped or injured, but has his head intact, he can cooperate with the rescuers and make the rescue much more easy. He said, I understand that point. He said, therefore, the only proposition is if you go climbing without a helmet, you understand that you're not going to be rescued. Now, it struck me, we know what would happen. And there is somehow a moral judgment here that we do not. Therefore, the financing becomes through the tax system, because the unequal distribution. I imagine you could think of, although it's difficult, insurance systems are adequate, but after all, they would be, the ability to buy this insurance would be related to income. Let's for the moment imagine we can overcome all these moral hazard issues. We can have really good insurance that really serves the proper function. Nevertheless, you would have the problem that after all, health costs are by no means proportional to income. They go up less than income. And obviously, if you take the average health cost is what, about 6,000?
About 8,000.
8,000, okay, $8,000 per person? Mm-hmm. Yeah, $8,000, it's a $32,000 for. Well, it's obvious what an insurance adequate to cover that would not be sustainable. So we have Medicaid, and so in other words, it's the if you take a narrow economic point of view, you'd say what you've got is a lot of taxation. Taxation is distortionary. The costs are really higher than the money cost because there is a classic welfare loss due to excess burden due to taxation. And it seems to me that's why all these special problems arise, because we're saying we're going to pay for it by taxes, some way or another. And maybe you can hide them a little bit, but that's what it's going to amount to. Taxes mean a bigger role for the government, which we know is somewhat unpopular in some quarters. But even from a purely economic point of view, it does involve welfare losses, which have to be offset against what we think is against. Presumably, our judgment is, interesting, nobody's going to really repeal a lot of this stuff. The marginal group of uninsured is only 50 million. That's why we can talk about throwing them to the dogs. We're not going to throw them Medicare. And in fact, there's no great opposition to Medicaid. It strikes me. There's no big political opposition to Medicaid. It's, maybe the margin, but it's not. It's surprising to me that given the diversity of opinion, this is accepted, and that's why it becomes a big issue, I think, compared to that it might not if it was just a question of increased market share.
Well, I get the chance for the last word. Just two comments. One, we've talked about the incentives of the providers, and one of the interesting aspects of that talked about the peculiarity of fee for provider, where you have an incentive to sell more. The other one, of course, is the HMOs, where they get per capitation, and they have an incentive to provide nothing. You hope that a reputation mechanism works, but we know that reputation mechanisms don't work very well, particularly when their choices are limited. So that I just mention that because it highlights the difficulty of solving the incentive problem. If it were easy, we would have solved it by now, but it was clear is that other countries have done a better job, and part of it may be sense of professional responsibilities, the kind of ethical things that Ken was talking about. The second thing is we've been focusing on the healthcare sector, but we've said actually relatively little about health. We ought to always remember that the healthcare sector is an input to something that we really care about, which is health. And it's not the most important input. And that other things like nutrition, smoking, and drinking probably have more important effects on average, on a lot of the aspects of our health than does healthcare. The reason why this is partly an economic problem, of course, is that if we're going to be subsidizing the provision of medical care, it also raises question of our positions about taxing and subsidizing activities that affect health. Let me finally, I want to acknowledge I forgot, I should have said that in the beginning, the Columbia University Press, the Program for Economic Research, CEPA, and the Committee on Global Thought for putting together this program, and Laura Morrison and Robin Stevenson for putting the whole thing together, and thank you all for coming, and especially thank Ken for honoring us again with this, coming here and participating in this, and Amy for giving a wonderful talk, and John for a wonderful discussion. Thanks.